Welcome to the Surgical Edge Explainer. In this session, we're going to tackle a core challenge for every single one of us clinicians, mastering surgical risk prediction. The goal here is pretty simple, to cut through all the complexity and give you a clear, actionable framework you can actually use. Okay, before we dive in, just the important legal bit. This explainer is strictly for educational and reference purposes. It is absolutely not a substitute for your own professional medical judgment and advice. All right, let's get into it. So here's the game plan. First, we'll cover why this all matters so much. Then, we'll take a quick tour of the key scoring systems in your toolkit. From there, we'll look at how we match the right procedure to the right patient. And we'll wrap it all up by talking about what gives surgeons the modern edge. All right, Section 1. Why does risk prediction matter? Well, you've heard it before. You can't manage what you don't measure. Being able to accurately quantify risk, well, that's the absolute starting point, the cornerstone for effective patient care and surgical planning. This really gets to the ethical and practical heart of what we do. Think about it. A realistic risk estimate is the only way you can get to true informed consent. It's what turns a consultation into a real, shared decision, where you and your patient can get on the same page and maybe agree that a less extensive surgery, or, even no surgery at all, is the smartest path forward. And listen, these aren't just abstract numbers. They have real-world consequences. A predicted mortality risk over 5%? According to guidelines from the Royal College of Surgeons of England, that number automatically triggers a specific protocol. It means you have to get active consultant input at every single stage of that patient's management. And if you cross the 10% threshold, well, the requirements get even more intense. The procedure must be directly supervised by a consultant, and post-operative management in a critical care facility becomes mandatory. These are the non-negotiables, the safeguards we have in place for our most vulnerable patients. So you see, this isn't just about paperwork. Simply identifying a high-risk patient is a powerful intervention in and of itself. It sets off this whole cascade of better decisions that helps us allocate our critical resources more effectively, and most importantly, it directly improves patient outcomes. It's a huge deal. Okay, so now that we've established the why, let's get into the how. This next part is a practical tour of the scoring systems we use, the tools that help us put a hard number on our clinical intuition. So what's actually in our risk assessment toolkit? Let's break down the 4 main systems you'll probably encounter. First up is the ASA system, the American Society of Anesthesiologists score. I mean, it's everywhere for a reason. It's a fast, simple way to categorize a patient's physical status. But that simplicity is also its weakness, because it wasn't originally designed to be a super granular predictive tool. The main challenge with the ASA score is what it leaves out. It doesn't factor in the patient's age, and it doesn't consider the specific surgery being performed. On top of that, the term systemic disease can be pretty subjective, which can lead to different scores from different assessors for the same patient. Next, we have the POSSUM score. That's the Physiological and Operative Severity score. Now, this is a much more targeted instrument. It's designed specifically to predict mortality and morbidity for patients that are going to require post-operative critical care. Then there's Lee's Revised Cardiac Risk Index, or RCRI. The key thing to remember here is its laser focus. This tool is built to stratify cardiac risk for non-cardiac surgery. It's not for predicting overall mortality, which makes it a vital specialist tool, but only for the right patient. And finally, we have the ACS-NSQIP Surgical Risk Calculator from the American College of Surgeons. Now, this thing is a powerhouse. It's a web-based tool that uses 19 patient-specific factors to calculate risk across more than 1,000 procedures. And crucially, it tells you how your patient's risk compares to the average. Super powerful stuff. So here they are, all side by side. You've got the general overview from ASA, the high acuity focus of POSSUM, the cardiac specificity of RCRI, and the deep procedural detail of ACS-NSQIP. The real art is knowing which tool to pull out of the toolkit for which patient. So we have the tools, we have the data. Now let's connect all of that to the actual decisions we make in the OR, where risk assessment directly dictates our surgical technique. Laparoscopic surgery is a perfect example of this. For a patient with high respiratory risk, it's often the preferred technique because you get fewer post-operative respiratory complications. But take a patient with significant cardiac risk. For them, the pneumoperitoneum required for the procedure can have some really adverse physiological effects, making it a poor choice. Same procedure, completely different risks. This quote from the literature just captures the idea perfectly. The procedure itself is really only half the story. The true risk is defined right at that intersection between the procedure and the unique physiology of the patient who's sitting right in front of you. This is especially true in modern minimal access surgery, a robotic prostatectomy, for instance. That can require hours in a steep Trendelenburg position. In a fit patient, that's manageable, but in someone with underlying cardiac or neurological issues, that same positioning can provoke myocardial ischemia or raise intracranial pressure. Patient selection is everything. So let's bring this all together. What is the modern surgical edge, really? It's not a single tool or some magic score. It's the skillful integration of that objective data with our hard-won clinical judgment. This all really boils down to a clear 5-step process. 1. Identify the patient's risk factors. 2. Quantify that risk with the right tool. 3. Engage the patient in a shared decision. 4. Select the optimal procedure based on all that data. And finally, 5. Allocate your resources, like critical care beds, where they will have the most impact. Ultimately, mastering the surgical edge means becoming fluent in 2 languages: the quantitative language of data from these scoring systems and the nuanced language of our own clinical judgment. It's the synthesis of the two. That's what truly optimizes patient outcomes. Which leaves us with a really important forward-looking question. As our surgical techniques and technology continue to advance, how do we make sure our risk models evolve right alongside them to keep our patients safe? Thanks for joining this explainer.
Thank you for watching The Surgical Edge. Don't forget to like, subscribe and share the channel. You can also support us by joining and suggesting surgical topics that you would like us to cover. For more insights and content, do subscribe to our podcast.